Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a guest who is an emergency medicine resident who recently had an interesting patient. He wanted to come on the show and discuss it, and I was more than happy. Codey Pedersen is actually a resident I worked with, and while he was working in our pediatric emergency medicine department in Las Vegas, he saw this interesting patient, wanted to come on the show and present it, and I was more than happy to do so. Welcome, Codey, to the podcast. Glad you are doing this with us today. And let me just introduce you to the PEM Rules listeners so everybody knows where you are and what you are. You are originally from Redding, California. You went to medical school at Western University in Oregon. And currently, you are one of the chief emergency medicine residents at the Kingman Regional Medical Center program. The ED residents spend, correct me if I'm wrong, Codey, 1 month a year in second and third year. Is that right?
So we do first and second year.
First and second, sorry.
Yeah.
And we've been very fortunate to have them in our ER because they're super helpful and they help us be better physicians. So welcome, Codey, to the show. How are you?
Doing well, Yaron. Thanks so much for having me on. I'm excited to be a part of the podcast. I used it every single day driving to work to Sunrise during my rotation with you. And it's such an amazing resource for students, residents, and anyone who wants to learn the essentials in the practice of PEDS. So I'm super excited to be a part of it.
I appreciate that. And, coming from such a great resident like you who's hardworking and smart, it's a very big compliment. I really appreciate it, Codey. Thank you very much. Tell us first, Codey, just so you know, what do you do when you're not a resident?
When I'm not a resident, I'm the typical EM person. So I love the outdoors. I love hiking, fishing. Anytime I can go snowboarding, although it's kind of hard in the middle of the desert.
Yes.
But Flagstaff isn't too far away to go snowboarding. So nice. Just typical outdoorsy person.
Very nice. So I'll tell you my brief experience with snowboarding. I was a college student at Northeastern University in Boston. I grew up in Israel, not a whole lot of snowboarding over there. And I remember at the end of the day, I had pain in muscles I didn't even know I had. It was an incredibly eye-opening experience. It was a lot of fun.
Definitely.
But anyhow, I guess we're supposed to talk about medicine today. So recently, Codey, you had an interesting patient in our pediatric emergency department, and you saw the kid, did the right thing, applied some of the rules. So tell us about that experience.
All right. So this was a super interesting and fun case that had a great outcome, which is always a huge bonus as well. You and I had this patient together. We had a 14-year-old male presented to the ED for 3 days of progressive neurologic symptoms, starting with loss of fine motor skills. His parents said he started dropping things and seemed super uncoordinated, and then progressed all the way to ataxia, multiple falls, vomiting, and the last day he even had some incontinence. So came in on exam. He was generally well appearing, normal vitals. He was just laying in bed when I first saw him. And then I got into a neurologic exam, and it was significant for finger to nose ataxia. He could not touch my finger when I was holding it away from him. And then he had some vertical nystagmus and difficulty with fine motor skills. I put a pin down on the end of the bed and he could not pick it up. And then I also tried to get him up to walk, and he couldn't even take a step without falling over. I had to actually catch him before he fell over. So automatically with these physical exam findings and remembering your PEM rules, rule number 33 came up for me that if a patient can't walk home, he shouldn't be going home. So I knew this was something he would be staying for and needed further workup. So at this point, it was obvious that he had some major neurologic deficits and problems. My differential at this point was really broad, ranging from brain tumor to autoimmune disorders, some sort of infectious encephalopathy or meningitis, or of course, toxins, including recreational drugs or alcohol. So going on further with the case and getting a more thorough history, parents revealed to me that for the past 3 months or so, he had been pretty consistently complaining of debilitating headaches, and he was also progressively having problems with some memories as well. He had previously been seen for these headaches at his pediatrician's office, and they diagnosed him with dehydration headaches, which, as you know, in the middle of the desert in Las Vegas is pretty common. probably one of the most common causes of headaches. But digging a little further back, it was noted that the only other significant history he had was a pretty standard case of his head was a little big when he was born. He had a little bit increased head circumference at birth, but he pretty quickly grew out of that as he grew up. So at this point, I began to really use more of my PEM rules like we talked about and realized that, yes, I had a very broad differential at this point. However, I also had a patient that was vitally stable and while lying down looked well in front of me, was otherwise clinically stable at the moment with symptoms that had progressed over a matter of days to months. So within this in mind and remembering rule 3, the tempo of your intervention should match the tempo of the condition you are treating. And rule 4, less is more. I initially just ordered routine labs, including a UDS and alcohol level, to rule out some of the more common etiologies before I got too invasive or began ordering more intricate tests or imaging to try to avoid exposure to radiation, which, as we know, is such an important thing in pediatrics. However, when all of those came back normal, his UDS and alcohol level were negative, it was all time to move to the next step, be more aggressive, and order some imaging. And of course, this is where we got our answers. CT of the head revealed our diagnosis and what we were looking for. So it revealed severe hydrocephalus secondary to suspected aqueductal stenosis. And then subsequent MRI also revealed severe obstructive hydrocephalus with severe dilation of the lateral and third ventricle and soft tissue in the region of the aqueduct concerning for a web. So this is a super rare form of hydrocephalus and is exceedingly rare in adolescence, as most kids with an aqueductal web present much earlier in life. However, as I said in the intro, this case does have a happy ending, as he went to the OR with neurosurgery the next day and had an expansion of the third ventricle, which allowed exposure and communication with the prepontine subarachnoid space. And in a subsequent neurosurge follow-up 2 weeks later, he had a resolution of symptoms and was back to his baseline. So this was an amazing outcome and made it even better as we could have such an interesting and fun case with real neurologic findings. And it also ended up with a resolution of his symptoms.
Very good. So that is actually a really, really good case that I personally find very interesting. And I don't believe I told you at the time, but sometime in between undergrad and medical school, I actually didn't have to, but went to grad school and I wrote my master thesis on pediatric hydrocephalus. So this was right up my alley. And it is really rare for aqueductal stenosis to not present in a newborn. And I like what you did. I like how you phrased it because, number one, you saw the kid and you stayed a step ahead. So you knew that the disposition is going to be X. In other words, the patient is coming in regardless. And it's always good to be a step ahead. And I like how you recognize the red flags. As I tell the residents all the time, you clearly saw, it wasn't particularly challenging, but you clearly saw the neurological exam is abnormal. So there's a lot to worry about. And I like your approach of, getting those lab tests first, because as an ED physician, I always teach the residents, you got to check for what you can fix first. So you and I, unfortunately, cannot fix hydrocephalus or tumors, which we see. Those require head CT. You're not going to do the head CT before you get your tox screen and the electrolytes, because those can explain the findings and you can fix them. So you first check for things you can fix. That is really good that the patient had a great outcome, and I'm happy to hear that. Tell us more about the case and what else you learned from that.
Yeah, so this whole case basically reminded me, as you always say, rule number 1 applies to everything. So it isn't the patient's job to prove they're sick. It's your job to prove they are not. So I'm not sure how he presented to his pediatrician's office, but hearing a headache, you automatically are thinking, especially in the desert, like we talked about, dehydration headaches or something more common. So that's the first thing you think of. But when getting fluids and that kind of stuff doesn't improve your symptoms, then that's when you got to look more into it. So it just reminded me that, as in this case, sometimes a headache is not just a headache, and it is important to hold a low threshold for imaging and extensive workup when neurologic symptoms especially are involved. Because headaches, although are a common chief complaint in both adults and children, with usually benign sources, if there is anything abnormal or any neurologic involvement, it should be taken seriously. And those that are persistent deserve a more extensive workup.
I could not agree more. Again, this comes up all the time, essentially in any patients we see. Rule number one, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. And you did this perfectly. I also like the fact that, and that's another rule, listen to the primary care. Primary cares are physicians or clinicians. They know the patient, they know the family. If they are worried enough to send the patient to the ER, there's usually a very, very good reason. And I also like the fact that you recognize this is a benign complaint, but there are certain red flags that we as ED physicians should know everything about. Every chief complaint has red flags. You recognize that there are red flags here, and this needs more workup and potentially concerning. And I'm also glad you followed up on the patient, and indeed, that's good news. My experience with shunted kids is that the younger you are when you are shunted, the more likely you are to have complications, namely shunt infections, shunt malfunctions, because as you grow, those problems tend to occur. A teenager or an adult who gets a shunt usually have a very good prognosis. So that is indeed a very good outcome.
Yeah, it was great. It was great to see him improve. And it also reminded me, I mean, one of the biggest things, especially in EM, when we're trying to see as many patients as we can and get patients out of the waiting room, that the neurologic exam, especially for even a benign complaint like headaches, is just so important to do a full, thorough neurologic exam, because he had some really obvious findings, but if you were just trying to quickly go through it, you might miss something. And especially one of the biggest things is people don't always get people up to walk. And that was one of the most severe symptoms that he had, was he could not take any steps. So that was one of the big things for me too.
Very good. So again, I can't remember the numbers anymore, but one of the PEM rules is see the patient, not the waiting room. Every patient has a need, and they got to get what they need, regardless to how many patients are waiting to be seen. Easier said than done, especially in the winter when you know that waiting room is getting busier and busier. But essentially, every patient needs something from us, and regardless to how busy you are, you have to give the patients what they need. So great job, Codey. Thank you very much for coming on the show and sharing this with us. I'm sure you know the PEM Rules tradition. The guests get to choose the outro. Shoot me some bands and some songs that you want to hear.
All right, will do. Thanks so much for having me on. I look forward to listening to your future episodes and hopefully working with you a little bit more as if we get the chance.
Hopefully that'll be great. Glad to have you. Thanks again for coming on the show.
Yeah, thanks so much.
And that is it for today, guys. Thank you very much for listening to Codey and his case. Any of you residents or trainees out there who have an interesting case in pediatric emergency medicine and want to come on the show and discuss it, you're more than welcome to. Shoot me an email or a text via the website and I'll be happy to discuss it. As far as the outro for today, so to my surprise, Codey, despite his very young age, learned some really good music from his parents, and he likes classic rock. So this is AC/DC, Highway to Hell. Codey, I hope you like it. Thank you for all the help in the pediatric emergency department.